with Dr. Gil Lederman at the WOR Studios in the heart of New York City. We're just a few steps from the Radiosurgery New York Cancer Treatment Center on Broadway and 38th Street. Dr. Lederman, the leading cancer expert, treats prostate cancer non-invasively. He was the first in New York with fractionated brain radiosurgery, and he's the first in America and in the Western Hemisphere with body radiosurgery. You can also call Dr. Lederman at 212-CHOICES for a free informative booklet and DVD. Hey, Dr. Lederman, we're back.
Hi, it's Dr. Lederman. We're back on the Radiosurgery Hour, back about a lot of interesting things. I want to pop right in and talk about a 66-year-old man. He was seen at a big hospital. His PSA was not 7.1. It was not 0.71. It was 0.071. He saw a urologist there, and the urologist wanted to do a biopsy. Now, the patient thought it was suspicious, so he called us up for a second opinion. Came in this week, just saw him. I examined him. His exam is totally normal. His PSA was 0.071. Very low PSA. He asked me, why would a doctor want to do a biopsy on a prostate if the exam is normal and his PSA is so low? Well, I explained what I thought. I explained that there was no need for a prostate biopsy. If you don't need a biopsy, then there's no benefit in getting a biopsy. And this man agreed. We talked about all the reasons why someone might recommend a biopsy even though his exam is normal and his PSA is very, very low. So luckily, this man came, he saved a biopsy, he is happy, we're happy that we're able to do the right thing for him. And we try to do the right thing for everybody, by the way. Do any of you know what Barrett's esophagus is? Well, Barrett's esophagus, actually I had an uncle who had Barrett's esophagus and developed esophageal cancer and died decades ago. Barrett's esophagus is when the lining of the esophagus, which is the food tube between the stomach and the mouth, when that lining changes. The lining is one particular way, and sometimes at the bottom of the esophagus that lining starts changing to reflect more the lining of the stomach. So remember, there's a connection at the bottom of the esophagus between the esophagus and the stomach. The lining of the esophagus is one way, the lining of the stomach is another way. God probably made those linings to give us the best chance to be normal. Well, if you have Barrett's esophagus, the chance of esophageal cancer increases by 10 to 55-fold. So huge, it's from 1,000 to 5,000% increase in esophageal cancer. So it's really critical if you have esophageal reflux or esophageal symptoms to find out if you have Barrett's esophagus and treat it, because obviously no one wants to get a cancer, and especially not esophageal cancer. Now, there's a new article that was just published by Astro Post, and the lead author was a doctor named Hashem El-Sarig from Texas, and he and this group looked at possible protective effect of statins. Statins are those drugs that many of us take to lower the cholesterol, and they found that there was a protective effect of statins, especially in obese patients with frequent gastrointestinal reflux symptoms, and for those who took statins for more than 3 years. So statin use was associated with a reduced risk of developing Barrett's esophagus. Obese patients had the greatest reduction with statin use. Statin uses have been associated with reduced risk of esophageal cancer, and this is one of the first articles to look at that. This again was published in ASCO, ASCO, which is the American Society of Clinical Oncology post, and was based off of study from Hashem from Texas. Barrett's esophagus only affects 1 to 2% of the general population. But the problem is, even though it's a small percent, it increases dramatically the chance of esophageal cancer. So it's a single study from a single institution, looked at 303 patients with Barrett's esophagus and 909 control patients treated in Houston, Texas, and they compared pharmacy records, and they found this protective effect against the development of Barrett's esophagus. The protective effect was especially in patients who were obese, having a body index greater than or equal to 30. They had a 74% reduction in Barrett's esophagus. And patients who had frequent gastroesophageal reflux symptoms had a 59% reduction in Barrett esophagus risk. This is all for people who use statins for 3 or more years, having the highest risk reduction. So it's interesting news how statins to lower cholesterol may help prevent Barrett's esophagus, which may help prevent esophageal cancer. We treat esophageal cancer, but we're even more happy if we can protect you from ever getting esophageal cancer. We've talked a lot about esophageal cancer in the last few weeks. We've had several patients treated with radiosurgery because their esophagus was closed, that had standard treatment, and the cancer came back in the esophagus. We treated the esophagus with radiosurgery, 5 treatments, and opened it up without surgery. We had another woman we talked about last week who had chemoradiation surgery at a famous cancer hospital and then had a recurrence of the cancer exactly where the surgeon cut, next to the incision site in the esophagus and next to the chest wound where he opened up her body. There was cancer. We treated both, and both were successfully treated. And this week we saw a man with Gleason 7 cancer who's treated elsewhere with radiation. And again, if you look at our booklet, you can see that the success of treatment depends on who treats you. So for Gleason 7 cancer, if you have surgery, and I know it's hard for many people to believe this, but if you have surgery for a localized cancer, there's actually about a 40% recurrence rate of the cancer despite the surgery. Why is that? Well, perhaps it's the surgeon spreading the crumbs. That's what I believe. So even the cancer is localized in the prostate, the surgeon cuts it out. For Gleason 7, there's a 40% recurrence rate, which means 60% success at 5 years. Our data shows a 90% success. And the same is true with standard radiation, 60% versus 90%. Well, what happens to those people who are caught with that lower success? Well, this gentleman had Gleason 7, 2005, had an elevated PSA, had a biopsy for Gleason 7 cancer, had standard radiation, and that treatment failed. So we are interested to find out why it failed and offer other treatment. His doctors started him on hormonal therapy immediately, and with hormonal therapy it will temporarily shrink the cancer, but we won't know where the cancer is. Has the cancer spread all over his body, or is the cancer localized? Obviously, we could treat in either case, but the intent of treatment is different. So radiosurgery and focal radiation works very well for metastatic cancer and helps relieve pain and helps prevent the bone from getting worse. Actually, many bones heal up completely. So there's lots to talk about for anyone with cancer. But again, the point is you may want to investigate what's the likelihood of success for my cancer. And not all prostate cancers are the same. Gleason was a pathologist, and he taught us how the pathology indicates the aggression of the cancer. So a low Gleason score has a different success rate than a high Gleason score. A patient that comes with a low PSA has a different success rate than someone that comes with an intermediate or high PSA. And stage 2 is important. So give us a call if you wish, if you're confronting prostate cancer. This man certainly wished he had, because now he's stuck with a recurrent cancer. We're trying to get the hormones out of his system to see exactly where the cancer is. And he's had a lot of side effects from hormones. He doesn't want to be on hormones, and hormones obviously don't cure anybody. So we'll report back to you where his cancer shows up when the hormones get out of his system, which may take a while, may take a few months. Now here's a man who was really upset, 79-year-old man, sent by his doctor to us, had a big mass the size of a golf ball in his face. His doctor said, I think it's a cancer spread from his colon. I think it's a cancer. He's really in trouble. This man came with his brother, fearing the worst, fearing that he had cancer, and he came to us for radiosurgery. Well, again, there's a series of steps that need to be done. So if he just called me up and said, what do you do for a cancer in the face? He'd get one opinion. But if he comes and sits down, it's easier to do the right thing. And that's why we urge people to do the right thing. Don't cut the corners. He came to us. We got him biopsied and staged. He thought he had cancer and didn't need anything. Well, we got him biopsied, we got him staged, put a little needle in that big mass, which was rock hard in his right face, the size of a golf ball. Where it was affecting the masseter muscle, so he couldn't open his mouth. He could barely eat because of this mass. It was a little bit uncomfortable, but it was very worrisome and massive. Stuck a needle in, and guess the answer. Yeah, it was infection. Pus came out. No cancer. So when I met the man, I said, just because you have a mass doesn't mean it's cancer. Not all masses are cancer. So we urge people who have masses, who have lumps or bumps or worried about the worst, don't stay home and worry. Let's do something about it. This man came in. We did something all in one day. We got him scanned. We evaluated him, stuck a needle in, got out pus. This guy is about the happiest guy in the world because despite everyone telling him he had cancer and his fear that he had cancer, in fact he had something else. So it's another example why it might be worth your while to come in, whether you have cancer or not, infection or not. It may be worth your while to follow the rules and get the right thing done and try not to cut corners. And we had another man who came in this week, 72-year-old man, married with a lung cancer. He had an abnormal chest x-ray, he had a mass in the left upper lobe, he had a PET scan, and he had surgery for adenocarcinoma of the lung with positive lymph nodes. He had poor kidney function. He had chemotherapy, which he finished 6 weeks ago, and now he has new headaches. The new headaches prompted an evaluation of his brain, and the cancer, despite chemotherapy, spread to the brain. He lost 10 pounds. He went from 135 down to 123 pounds. He started Decadron, which is a steroid medicine to reduce the swelling in the brain. His doctors wanted to remove the cancer in the brain and tested for different chemosensitivities to try to find a chemo that's custom made for him. He also has some nodules in the lung, so it may be possible to look at that from the lung if he wants custom made chemotherapy. I spoke to him about focused radiation, and our success rate is very high for brain metastasis from lung cancer, whether it's adenocarcinoma, squamous carcinoma, non-small cell, or even small cell. So with us, there's no cutting, no bleeding. Brain cancer treatments, like for this metastasis from the lung, we commonly see them because there are about 250,000 lung and other primaries that spread to the brain each year in America. So with us, we can avoid the cutting and the bleeding and the hospital stay and the anesthesia that's associated with brain surgery. Again, we have 3 separate booklets. One is about brain tumors, one is about prostate cancers, and one is about general body cancers. It won't tell you exactly the recipe for your care, but it gives you an idea of the kind of work that we do. So to get that, just call us during the work week at 212-CHOICES, 212-CHOICES, which is 212-246-4237. 212-246-4237. Call us at Radiosurgery New York. My name's Dr. Lederman, and we're going to hear from some voices, and we'll be right back.
For cancer treatment, most prefer effective, non-invasive, well-tolerated outpatient therapy. With Dr. Lederman, the radiosurgery pioneer, that's our goal too.